Good evening. My name is Dr. Stacey Harris. I am a paediatric doctor and also this year a leadership fellow in sustainable healthcare. So I just wanted to just go over sort of why we're here, talk about the climate emergency, talk a little bit about the general impact of healthcare on the climate, and then talk a little bit about sustainable healthcare within Wales. Just a whistle-stop tour. So I'm just trying to click forward. There we are. So putting it simply, the climate emergency is a health emergency, and I'll go into this in a little bit more detail. And so this is from the Lancet Commission on Health and Climate from 2015. And if current emission trajectories continue, it poses an unacceptable and potentially catastrophic risk to human health. And that threatens to undermine the last half century of advances in public health. But I'm an optimist, and I want to take this as an opportunity. And this is actually the greatest global health opportunity of this century. So, you know, there's lots of work to be done, and we can really make a difference in this field and transform health as we go along. So this is just an infographic of the broad impact of climate change on health, and you know, it is very, very broad, and I'm not going to have the chance to go into this in huge detail, but you know, as we know, we're going to have increasing severe weather events, which have impacts on fatalities, mental health impacts, injuries, and then air pollution has an influence on cardiovascular disease risk, and also exacerbates asthma. We're going to see we're seeing changes already in this country of changes in vector ecology. Things like malaria, especially, are important to the UK, and actually in the south coast we are starting to see mosquitoes which do carry malaria. And then increasing allergens, so which will increase sort of respiratory allergies. Water quality impacts are also obviously because we have because of our climate. So we'll be seeing changes in our water quality impacts as well. And then, you know, so extreme heat related illnesses as well. And this is an infographic which the Public Health Wales has recently published. And I really like it because it brings it home to Wales. With climate change, sometimes it can feel like climate change is happening and affecting people in other places and not necessarily in Wales, but it is affecting people in Wales. And I'm quite staggered by these statistics that by the 2050s in Wales, the annual temperatures are projected to rise by 1.2 degrees. Summer rainfall is expected to decrease by around 15%. Water rainfall is projected to rise by 6%, and sea level is projected to rise by 22 centimetres. And it's really very staggering because you know, a lot of Wales is you know, near the sea, and just think about how that might affect those communities. And what's really important to remember when we're thinking about the health and well-being impacts of climate change is that it will affect those who are most vulnerable in our society. So older people, those with disabilities and long-term health conditions, those who are economically deprived, and also children and young people. This is an infographic just showing the different and complex ways in which climate change will be putting pressure on the healthcare system. And it really is very complex, but this infographic kind of puts it all together. It's just a broad overview. But the healthcare sector itself, despite being vulnerable, has an impact on the climate emergency. And this is a graph from the Sustainable Development Unit, and we do have one of these which is very similar in Wales, but I just prefer the way this one looks. And it illustrates the carbon emissions as proportion. And the NHS's carbon footprint in Wales is over 1 million tonnes of CO2 equivalents. And as we can see, it really is spread across lots of different parts of the system. So, you know, we kind of, I think we've been thinking about buildings energy quite a lot, and lots of our efforts have been focused on buildings energy, but that's actually only 10% of the picture. You know, when it comes to patient and staff travel, You know, that's around nearly 10% with staff and patient travel there. And then if you just look at this huge part, over 60% of the emissions are from medicines and chemicals, medical equipment, and also this supply chain as well. And then, you know, you've got here anesthetic gases and metered dose inhalers, just on its own being around 5% of our emissions. So if the global healthcare sector were a country, it would be the 5th largest emitter on the planet. And I always find that staggering, no matter how many times I hear it. And this is just another graph which shows the different sort of carbon hotspots within the healthcare sector. And the carbon hotspots will be different depending on which part of the system that you work in. So actually in general practice, the biggest carbon sort of hotspot is pharmaceuticals. And then it goes to kind of the business services and things. And what I think is staggering about this is that often when we think about sustainable healthcare, lots of people talk about waste and recycling and things like that. And this is the carbon footprint of waste disposal. And, you know, obviously waste has lots of other environmental impacts other than the carbon emissions. But actually waste disposal is just a tiny percent of our carbon footprint. So it's just really important to, when we're thinking about how we might reduce our carbon footprint, that we think about where we should put our efforts. So this graph on the left-hand side here is all of the things that, some of the things that we can do as an individual person in society. You know, like living car-free, having an electric vehicle, reducing our flights that we take, using renewable electricity. But really, our role as a healthcare professional and as one of the most trusted, you know, members of society, we have a real role in being that lever for change for the rest of society and modelling what can happen. Here we go, and we got a cycle ambulance here. So there's lots of ways in which we can sort of model good practice. And our influence on the environment from a professional point of view, sorry, I'm finding it difficult to make it go through, far outweighs anything that we can do as an individual in society. So what is sustainable healthcare? So sustainable healthcare is healthcare that meets the needs of the population now, so in 2022, but also means that we can meet the needs of future generations, so in 2050 and beyond. That's very broadly. So I'm struggling to get it to move forward for some reason. So if there's one slide that I'd like you to remember from my presentation, it would be this one and probably the next one. So, and when we're thinking about the principles of sustainable healthcare, often we think about things like low carbon alternatives. So that's prioritizing treatments and technologies with a lower environmental impact. But really, it's much broader and much more holistic than that when we think about sustainable healthcare. So the first principle of sustainable healthcare is prevention, and that's all about promoting health and preventing disease by tackling the causes of illnesses and inequalities. And, you know, this is actually where we can have the greatest benefit, probably. You know, we really want to make sure that people are staying well, staying in their communities, and not necessarily needing to see a healthcare professional, needing to be admitted to hospital, and really, you know, really from a prevention point of view, doing our best from that point of view. And then when it comes to number 2, patient self-care, that's all about empowering patients to take a greater role in managing their own health and healthcare. So, you know, educating them on their illness or their disease, or how they can be healthy, things like patient apps and things like that. And that's really important, that we're able to empower patients to, you know how to look after their own health. And then lean service delivery. So that's all about streamlining care systems to minimize wasteful activities. And I'm sure if you've, you know, worked in the NHS for a period of time, you would have seen lots of ways in which there's wasteful activities within our systems. So, you know, that would be one way of reducing the carbon impact, but also increasing the sustainable value. So again, this is another kind of take home equation. So when we think about sustainable value, we actually think about it really holistically. And patient and population outcomes are at the top of the equation. We want to maximise patient and population outcomes, but we want to make sure that that's underpinned not just by financial value, so making sure that we're delivering value for money in healthcare, but that we're maximising social value and reducing as far as possible any environmental impacts. So this is called the triple bottom line. So it's not just the bottom line as sort of traditionally we've known about, but the triple bottom line. So I just thought I'd bring it to Wales and tell you a little bit about what's going on in sustainable healthcare in Wales. And this is a very fast moving and evolving field. And the NHS Wales Decarbonisation Strategic Delivery Plan was published in March last year. And this is a must read, and it's got lots of different initiatives inside of it. And the aim of that is stated in this NHS Wales Decarbonisation Strategic Delivery Plan is that we, as a public sector as a whole, so that includes Natural Resources Wales and the NHS and the rest of the public sector, are net zero by 2030. That is pretty ambitious. That doesn't feel like very far away. And the sort of incremental reduction is that by 2025, we've reduced the carbon emissions from 2017-2018 by 16%. And by 2030 by 34%. So that's just the NHS. And then when you look at the NHS decarbonisation strategic delivery plan, it's a bit of a tongue twister. It's got 6 main activity streams, and actually now is going to have adaptation as part of that as well. So in general practice, you'll probably be considering all of these actually. But I've kind of covered approach to healthcare a little bit in more detail. So when you look at it, there's lots of different initiatives around smart working, sustainable healthcare education, medical gas decarbonisation, transition to low carbon inhalers. And I know you're going to hear a bit more about that later on, reduction of pharmaceutical waste, reduction in plastics in healthcare, and then responsible disposable inhalers. And this was published in March 2021, but this is kind of just the start of how we will be approach to healthcare. I feel this strategic delivery plan. I feel will be actually developed there's a plan for a new one in 2023, which will hopefully look at it in even more holistically and slightly differently to the initiatives that are here now. So this is Green Health Wales. Green Health Wales is a network of healthcare professionals who realise that the climate crisis is a health crisis and are working towards making the healthcare system in Wales more sustainable. And we launched in June 2021 with an annual conference, which had lots of attendees. And our aim really is to connect, learn and transform healthcare in Wales to be more sustainable. And I'll tell you a little bit more about sort of how we go about that later on. So our overall kind of dream vision is that we're able to deliver healthcare without harm to people and the planet, and that we're acting positively to climate and nature. And like I said, our mission is to do that by connecting, learning and transforming. So connection, you're all here and meeting other like-minded professionals and connecting. And I feel that if when we connect, we saw the power of networks during the coronavirus pandemic, didn't we? And we can really use that power of networking in this challenge that we're facing, connecting with other individuals, finding out what they're doing, what best practice is happening. And on the Green Health Wales network, you can search by location and speciality. And if you're a general practitioner, greener practice is the place to go. But it may be that in order to do sustainable quality improvement projects, you really do need to connect across boundaries, and boundaries that perhaps you wouldn't traditionally be crossing. But this is one of those challenges that requires that across boundary leadership. And then learn. So I don't want anyone to kind of get into the mindset that you need to know a lot about sustainable healthcare or the climate crisis in order to act. I'm kind of a big picture thinker, and I just need to know enough in order to act. But if you did want to have a little look and, you know, develop your knowledge in this field. On the Green Health Wales website, there's lots of different areas in which you can learn about. So you can direct you to the Centre for Sustainable Healthcare, various webinars and online resources and things that you can look at. And this is kind of being updated, and as things come along, we add this to the website. But please don't feel like you need to know everything in order to make transformational change. And then Transform is all about actually undertaking quality improvement for projects. And our aim within Green Health Wales is to have a repository of all these case studies. And, you know, this is an evolving and developing field, and actually our website probably doesn't reflect all of the things that are going on, but that is one of our aims, is that we're able to put those case studies on display on our website. So this is a save the date. This is our next annual conference, which is happening on the 23rd of June. And it's a packed programme with lots of, collective leadership, lots of senior leaders and other leaders within the NHS in Wales. And it's a really varied and informative conference schedule, and I think it would have something for everybody. So we've got various sort of panel sessions with senior leaders, and we are talking for Wales and beyond, and then we've got some workshops in the afternoon and lots of different case studies and showcasing what's going on across Wales. So please put this in the diary, and we'll be sure to kind of share further details with you when they become available by your greener practice.
Hi, so there we go. Let me just get to the start. So my name is Dr. Sarah Williams. I'm a GP in Crickhowell. So Iechyd Cynnaladwy Cymru, so Croeso. So welcome to Greener Practice Wales. So as Stacey's kindly pointed out, we've got our Green Health Wales group, the website there, of which Greener Practice Wales is the GP group associated with that. And obviously we have the UK website and obviously the founders, Artie and Honey. So we have two resources there. So as Stacey's mentioned, we've got the decarbonisation plan. So initially, I've been working alongside sort of Stacey in a few projects over the last year. You might think you might have to move a mountain or carve a stream to have some kind of impact on global warming, but yet in just a year we've made some quite transformational changes associated with ICST and Dr. Simon Barry, respiratory consultant, who's going to talk shortly. So it just shows, you know, what can happen in 12 months. So specific sort of global warming effects for GP surgeries in Wales, we know that there are just over 20 GP surgeries on flood sites, as Stacey mentioned. With the rising sea levels, this is an increasing concern. We know that there are 2,700 deaths due to air pollution in Wales. And something that we have very specific to Wales is the Future Generations Act. And we have a commissioner, and that just is in our nation in Wales, which is designed around policy that we protect the future of children. And that means a huge part of that is ensuring children have access to a safe future. So it means safeguarding. So when developing sort of new and ongoing schemes, public bodies have to adhere to that. So an example locally is the Heads of the Valley Road is now down to 50 miles an hour to reduce the level of pollution. And so somebody that works locally, you know, that is the knock-on effect, hopefully reduced asthma attacks. So, you know, it can have a direct positive outcome for our patients. So Welsh primary care hotspots, so these are looking specifically at areas we should be focusing on in GP. So this is a combination of looking at sort of what's been produced research-wise, BMJ, Matt Sawyer, who's going to talk shortly, and greener prescribing. So like Stacey said, pharmaceuticals, and a big area is low carbon inhalers, and we'll be introducing all the resources we have for that. And we also have Sian Evans and Anne Harrod from Public Health Wales, who are going to talk about their greener primary care framework and award scheme for Health Toolkit. And I know lots of GP surgeries in Wales showed interest. I think there are maybe over 100. So this is a really good way to decarbonise your surgery. And something really specific to Wales we should be calling for is e-prescribing. So currently we're doing paper prescribing, lots of printing, lots of patient travel to and from surgeries, pharmacies to get these prescriptions. And I think we don't have a carbon footprint for that, but I think if we did, it would potentially be quite significant. And then another area is social prescribing. So there's the Welsh Social Prescribing Network. You can join that. It shows all the social prescribing activities across Wales. So locally to me in Powys, we use Mind, and we have a social prescriber there. And we also have one coming to the surgery as well, and we have Fathom Trust, a mental health organisation where we can direct our patients, and that's they're getting treatment therapy and they're not needing medication, which is a really good and positive avenue for us at the moment. Further hotspots, recycling, renewable energies, Stacey stresses probably should be really up at the higher end of the list there, and remote consulting where appropriate. So we're currently working with Respiratory Innovation Wales, looking at inhaler recycling. And there are many schemes. I know some surgeries, I think is at Port Talbot, they're doing IPAT. But that is definitely, I think, hopefully over the next year, we'll have a little bit more information to give about what we're doing about inhaler recycling, and where that's going to lead us. So that's a rundown of everybody that's going to talk tonight. I've already introduced them sort of slightly. We're going to have a break roughly around 8 o'clock, and then go into some case studies there. And then the Welsh Dashboard, so very specific to Wales, run by the All Wales Therapeutics and Toxic Centre there. So they're going to present the resources they have for us as well. And then we're going to end with Dr. Richard Thomas, who's been one of the founding members of Greener Practice Wales and worked on lots of areas already. So he's going to sort of end the session for us. So one thing I should mention, so if we do have anybody that's not within Wales and tuning in tonight, is Greener Practice, the UK website, has launched their high quality and low carbon asthma care toolkit. The rest of the talk we will be focusing on sort of the Welsh toolkit that's been developed. And again, just a little reminder there of a save the date for the conference that's coming on the 23rd of June. So we're involved with that. So Greener Practice Wales is involved with developing that conference. And last year we presented there as well. So I would highly advise, it's a really good day with really good content. Okay, so that's it really. Thank you.
Right, thanks very much. My name's Simon Barry. I'm the lead for the Respiratory Health Implementation Group. And basically, I'm going to focus on inhalers here. Next slide, please. Next slide. So basically, what we've done here is try to create a whole toolkit for delivering the innovations and implementing the innovations that we need to create reductions in the climate impact from inhalers. And we have a digital partner, which is the Institute for Clinical Science and Technology, who creates all of the innovations for us. Next slide, please. So you've already seen from Stacey's presentation, inhalers are a significant part of the carbon footprint of the NHS, and it's somewhere between 3 and 3.5% of the total carbon footprint, which is actually an enormous amount when you think about it. Just from pressing a small inhaler creates such a huge carbon impact. And next slide, please. So basically, here's the nuts and bolts of it. So currently, the graph and cloud on the left is where we are now. And this is all about different types of inhalers. So if you use a metered dose inhaler, which is traditionally the most commonly prescribed type of inhaler in the UK, that contains a propellant, and that propellant is an HFC, a hydrofluorocarbon or a hydrofluoroalkane, whereas in the past that was a chlorofluorocarbon, and they were banned more than 10 years ago because of their impact on the ozone layer. But the replacement, the HFCs, although they don't deplete the ozone, they have a very bad global warming impact, and they have many thousand times the impact of carbon dioxide in terms of global warming. So now almost 70% of the total number of inhalers that are prescribed in the UK are metered dose inhalers, and that amounts to 65,000 tons of carbon dioxide equivalent every year in Wales alone. So we've set a very stringent target, and by 2025, we want to reach a target where we move from 70% of meter dose inhalers to less than 20%. And that will reduce the carbon footprint from 65,000 tons to 20,000 tons. So there's a 45,000 ton carbon dioxide equivalent reduction each year in Wales alone. Now, why I wrote this in the decarbonisation strategy document, and the reason I chose 20% is because the best performing European countries, such as Sweden, have less than 20% of their inhalers are meter dose inhalers. In fact, in Sweden, it's 14%. And that tells you something very important, which is that it has nothing to do whatsoever with whether the patient can or cannot use a particular type inhaler. It's all about prescribing culture, because you cannot possibly say that in Sweden, they're far more able to use dry powder inhalers than they are in England. It's about prescribing culture, and it is prescribing culture that we want to change. Next slide, please. So here's a little bit of interesting data which shows you the prescribing trends over the last 5 years. And this graph is interesting, particularly because you will notice that there is a massive spike in March 2020. And in March 2020, that's when the pandemic hit. And a lot of inhalers were prescribed. And if you look at the graph on the right, you'll see the top graph is, the top line is for SABAs, so salbutamol essentially. And you'll notice that there were more SABAs prescribed than any other type of inhaler. So maybe GPs and maybe hospital consultants and others were prescribing these inhalers saying, well, we might not see these patients, so we're going to prescribe them. But it's intriguing to me that SABAs were the most prescribed group of inhalers, because they are by far the least effective. Next slide, please. So here's the graph, and each of those columns represents a year between 2015-16 to 2020-21. And you will see in the middle that by far the most frequently prescribed inhaler is the salbutamol MDI. By far the most. And yet this is the most ineffective inhaler that we have by a country mile. Next slide, please. And here is the data by different health boards. And what this shows is the percentage of dry powder inhalers and mist inhalers as a percentage of all inhalers. And you will notice that I've said that by 2025, we want 80% of the inhalers to be dry powder inhalers or mist inhalers. And here shows the trend over the last year, a number of years from 2018. And what you will see is that we're not improving. And in fact, I have an updated graph down to December 2020. And in fact, it's all getting worse in every single health board. So despite everything that we know, it's all going the wrong way, which is really quite depressing, actually. And we really need to do something about that. Next slide, please. So basically, what we've done in consultation and working together with the ICST as our digital partner is we've created a toolkit for this. So none of these things exist outside of Wales. They don't exist in England. They don't exist in Ireland. They don't exist in Scotland. They don't exist anywhere else. These are unique to Wales. And they're all free, and they're all freely available to Welsh healthcare professionals. So I'll just briefly take you through these. So we have national clinical guidelines. So I reviewed a paper not that long ago from about the green agenda in England, and it turns out that almost every CCG has a different prescribing pathway, and there are many, many CCGs in England. And previously, before I started as national lead, we had 7 different ways of managing asthma and COPD in Wales, according to which health board felt was the most appropriate way to do it. And clearly, that's not appropriate in a country of 3.2 million. So we got a consensus view, and in fact, and 98% of healthcare professionals were supportive of having national guidelines, and we created national guidelines, and they were produced initially in 2019. And we updated them more recently, and they were passed through AWMSG. And those guidelines very strongly indicate the carbon impact of different types of inhalers. So there are green and red footprints depending on whether inhalers are high or low carbon footprint. We also have standards, so we have a National Welsh Standard for education. So if you're a practice nurse who's doing an asthma or COPD annual review, then there is a standard educational package. And again, that will engage in the green agenda. We have QI projects, and there is a national QI project around sustainability that's been passed by Welsh Government. And lastly, I think this is really important. This is about involving patients. It's about co-production. So we have a suite of patient apps for self-management, and those are for asthma for adults, asthma for parents or children with asthma, and COPD. And those embedded within those apps is the green agenda. So the patients can actually drive the change in inhalers. And my experience as a hospital consultant is I've had one patient who says, I don't give a stuff about the environment. They all are interested in the environment just the same way as we are. Next slide, please. So we've seen all of this. We know that there's Greener Health Wales and Greener Practice Wales we're talking about now, and ICST, as I've mentioned, is our digital partner. Next slide, please. So I've talked a bit about the guidelines. They are interactive. They have QR codes that link to videos about the issues. I won't spend too much time on them. They're detailed. We've sent these out to every practice in Wales and all hospitals as well. Next slide, please. So that's a little bit more just showing you the COPD and asthma guide. Just one, I'm going to focus just actually on a couple of things while we're here. So the COPD guidelines, I mentioned to you before that salbutamol is by far the most commonly prescribed inhaler, but yet the least important. So on the left is the COPD guideline, and you will see at the bottom right our SABAs. Now, we've changed our recommendations now that SABAs are only recommended for patients having an exacerbation. We do not recommend that you prescribe SABAs routinely. Okay, so you don't prescribe, salbutamol MDI 2 puffs 4 times a day. They're only prescribed during exacerbations. People with COPD have reversible airways obstruction, and short-acting beta-2 agonist is a very ineffective treatment. And usually, basically what we're dealing with is very much a psychological effect of feeling the propellant in the back of the mouth. And most of these patients, as we know, do not use a spacer anyway. So it's an entirely ineffective form of treatment. And the other thing on the right is asthma. So if you use a SABA more than 2 puffs per week, by definition, your asthma is poorly controlled. So there's a major issue if your patient is actually requesting multiple doses, multiple SABAs, and that suggests that there's a problem. And that is something that is a red flag in terms of asthma management. So really, they shouldn't need their SABAs at all. So basically, in an ideal world, we would have no SABAs, because SABAs are ineffective and they indicate your asthma is not properly controlled. So there's and yet this is the most commonly prescribed inhaler, all right? And, prescribing that inhaler for a breathless patient is totally inappropriate when there's no evidence of airways obstruction. It is not the right thing to do. Next slide, please. So we've got the patient apps. I mentioned those before. These are super important because this is co-production. This is about working with patients to manage their own disease. We know in the past that through the Asthma UK annual surveys that only 25% of patients have basic asthma care defined by whether they have annual review, whether they have their inhaler technique checked, and whether they have a self-management plan. The self-management plans are all built within the app. This is a very sophisticated intervention. Next slide, please. That just takes you through some of the viewpoints about it. It links into, once you put your inhalers in there, links into videos about how to use them, and we can get monthly checks on your asthma control as well. Next slide, please. They're bilingual as well. Next slide, please. So that goes through those interventions. The other thing we're trying to do is work with patients in terms of trying to get them to actually address changing inhalers with GPs. So we have created a poster, but we haven't actually sent that out to practices yet. But we've also created a short video which can be run in GPs practices addressing the climate agenda, so that can be run, and that can provoke patients to actually challenge their practitioner to change their inhalers. And as I said previously, almost all patients seem to be very strongly involved in this agenda, just like we are. Next slide, please. So lastly, it is about script switch. That's on the GP systems, which challenges GPs maybe to think about whether they're prescribing something. It's got to be used very carefully, and we've tried, and traditionally this has been done differently in different health boards, but we've tried to get an approach whereby we do this as a standardized way, and I think that is working now. So if you switch from salbutamol to salamol, then you reduce the carbon footprint by 50%. If you switch from salbutamol MDI to salbutamol easyhaler, you reduce the carbon footprint by 98%. The problem with a switch of inhaler is that it does require, where you're changing the inhaler type, it requires the patient to be shown how to use that inhaler and to demonstrate that they can use it correctly. So you can't just do that remotely. So in one way, if we switched all of salbutamol MDI to salamol, we would reduce the carbon footprint of that by 50%. But actually, if we had an intervention which involved a healthcare professional and we switched them to a dry powder inhaler, we would reduce that by 98%. So that's a much bigger gain. So there's swings and roundabouts to script switch. Next slide, please. So basically, what we've done, well, I've presented this to NHS England as well, and they don't really have anything like this that's as joined up as this. So we've got, you'll hear later from Kath about the data that's been collected, which is fantastic. We've got lots of data on what's being prescribed. We've got national guidelines, they don't exist anywhere else. We've got national apps, which are free for patients, which are, they don't exist anywhere else. Well, there are some apps around, but you've got to pay for them, and they're not linked into a whole system. We've got educational components for healthcare professionals that link into the green agenda. We got script switch, and we got some comms structures as well. And lastly, the other thing I should mention as well is about the diagnosis. So, it's a big carbon footprint, and we know that about 25% of patients on COPD registers do not have COPD, and about a third of patients on asthma registers do not have asthma. And if you add those numbers together, that's approximately 100,000 patients in Wales. And the total financial cost in terms of inhalers is around about £20 million. And the carbon cost is 20,000 tons of carbon dioxide each year. So getting the diagnosis right is super important. We're very focused on that in terms of reinvigorating spirometry in primary care, and also delivering pheno. And I've had a meeting just today with the AMDs of primary care to try and address this agenda. So that's the end of my talk. Thank you very much.
My name's Sian Evans. I'm a consultant in public health and I work in Public Health Wales. I'm a pharmacist by background, and I was one of those people that Simon was talking about earlier. They used to go into practices and be nagging practices to do script switch and various changes. So I've kind of tread the boards in that sense. I'm joined tonight with a colleague of mine, and Howard Wooldridge, who's going to co-present this with us. And I'm going to spend about 10 minutes just talking you through a scheme that we've developed in Wales, particularly for our Welsh practices, but also for other primary care contractors. Next slide, please, Jenny. Okay, this is what we're going to cover. Because we're pushed for time, I'm not going to read the slide. It'll just go out with the slide back at the end. Okay, next slide, please. Okay, so again, some of this has already been covered. Stacey's talked about the emergencies. She's talked about the fact that there are targets in Wales now. Talked quite good length around the strategic delivery plan, and the importance of that is when I talk to you about the framework, a lot of our work maps back to this. The importance around the health sector and the contribution they make towards carbon emissions. But the last but one bullet is that when we've looked at this, there's no bespoke environmental sustainability tool for all primary care contractors in Wales, and that's the angle we've come in when we're looking at this particular piece of work. And I've stolen this from a colleague who is on the call, who may well remember saying this to me once before, that we feel that there's a personal responsibility, a professional responsibility, and an organisational responsibility to act, and that's where we're hoping our framework will sit, is it trying to tick off all those areas. Next slide, please. And I think it might be Howard. I'm handing over to Howard.
Thanks, Sian. So like Sian said, my name's Howard Wooldridge. I'm a senior public health practitioner in the primary care division of Public Health Wales, and I'm leading on this piece of work with Sian. So I'd just like to start by explaining what our work is. It's an online sustainability framework which is accessible to anyone working in general practice, community pharmacy, optometry and primary care dentistry in Wales. The framework itself contains approximately 30 generic climate change mitigating actions, which any one of those 4 settings can achieve. They're organised according to 8 high-level categories, and that's things such as procurement, waste and buildings and estates. And I've got some examples of the actions in my next slide. Each setting also has a small selection of contractor-specific actions which relate more to their clinical work. So, for example, the actions on inhalers are included within the contractor-specific actions for GP practices and pharmacies, but not in the dental or optometry versions. The actions in the framework were developed in collaboration with our expert group, and this consists of Welsh Government policy leads, professional bodies like the RCGP and clinicians as well. And we've ensured that our actions align to a number of key policy and legislative drivers, such as the NHS Wales Decarbonisation Plan, which has already been mentioned, the Wellbeing of Future Generation Act goals and ways of working, the UN Sustainable Development Goals, prudent healthcare principles, as well as other green impact toolkits, which are already around. So we've worked with the same charity that developed the RCGP Toolkit, SOS UK, and we've commissioned them to build and manage the online framework for us. They're also responsible for training the university students who volunteer as auditors as part of the awarding process, and there's more to come on that later in the presentation. So next slide, please. Okay, so here are 4 examples of the actions contained within the framework. The first 3 are generic actions, which any of the contractors can complete, whereas you'll see that the last action is one which is only available on the general practice version of the framework. I'll give you just a quick minute to read through these, and to note as well that 3 of the GP specific actions are on inhaler prescribing, and 2 of the community pharmacy actions are on inhaler disposal, which I've seen has been mentioned in the chat bar, and informing and educating patients on the carbon footprint of commonly prescribed inhalers. Okay, next slide, please. Okay, so the first step for an interested practice would be for them to access our online framework and read the information on the homepage. And then for anyone wishing to register, there is a registration form on the website which asks for some basic information. If you're a new user, then you'll need to email either our team, and we've got that email at the end of the presentation, or SOS UK for a registration code. And this is just a simple security check to stop inappropriate registrations. So if you're the first person joining from your practice, you'll need to set up. Lovely. Okay, so once you're logged in, you select your setting out of the 4 that I've mentioned, read through the actions available to you and decide which ones you want to attempt. So you can complete the actions in any order and in any quantity, but as the number of actions you complete increases, so does the number of points and therefore the level of award at the end of the year. To demonstrate completion of an action, you submit evidence onto the framework, and this could be in the form of free text describing what you've done, a document uploaded such as a meeting agenda, or a photograph. The framework will then close for evidence submissions in the autumn, and this is when the student auditors conduct their assessments to confirm the level of award that a practice has reached, so bronze, silver, gold. And we're hoping to develop an assets pack so that practices achieving an award can use our logo on their email signatures, on their website, their social media, and we're also exploring some other methods of rewarding this achievement as well. Once the audits are completed and we've updated the framework for a new year, it then reopens again so that practices can build on their progress and aim for a higher level of award the next year. Next slide, please. Okay, so at the moment, this is what the homepage looks like. However, before the launch, we want to add our own logo at the top of the screen so that it's easily identifiable as the Welsh Framework. And we'd also like to acknowledge on the homepage the endorsement that we've received from a number of the professional bodies, such as the RCGP. Next slide, please. Okay, so hopefully now you've got a sort of slightly better idea of what the work is. So I just want to quickly take you back in time to 2019, before COVID, to explain the journey that this work has been on. So in late 2019, our team started exploring the current green impact toolkits and scoping whether there was anything available for all contractors or for Wales specifically. And work was beginning to commence on this when COVID hit and all of our staff in PHW were redeployed, so work was paused. And during this period of time, the only really major development in relation to the work was that the Welsh Government published the NHS Wales decarbonisation plan. So then I started in post last summer, and having that decarbonisation plan was a really useful starting point for us to align our framework to. It was then around June last year, we also analysed the existing Green Impact Toolkit, so the RCGP Toolkit for GPs and the dentistry one, to see what actions would be relevant in Wales. And we started meeting with stakeholders to find out what they wanted in the framework. Has anybody else got feedback there? No, that's okay, it's gone now, fine. Lovely. Okay, so by September, we developed the first draft of the framework, and we'd also been awarded a Bevan exemplar status through the Bevan Commission, which we're really proud of. In October, we held the first meeting of our expert group, whereby each action was scrutinised very carefully and either included or excluded from the framework. Moving to December, then we started working with SOS UK. We commissioned them, and this is when our online framework that you saw the screenshot of really started to come to life and began to be built. We then put out a call for expressions of interest to join our pilot. I think Dr. Sarah Williams mentioned this earlier on, so some of you may have seen that flyer that came out back in December. And by the new year, we'd had over 140 expressions of interest from across Wales to join the pilot. And I did have a quick look on our spreadsheet. There was about 49 GP practices, so the rest of the 140 came from pharmacies, dentistry and optometry. So from that 140, we shortlisted down to 12 sites, which included 3 GP practices and 3 pharmacies in a mixture of different health boards in Wales. And we worked with them between January and April to test and refine the framework. And I just wanted to say hello to some of the pilot sites that have joined the call tonight. Thank you for joining. Okay, so the final 3 white boxes on this slide is where we are now. So we're evaluating the pilot prior to national launch in June. And actually yesterday we held our second expert group meeting. Okay, next slide, please. Fab. Okay, so just to pick up on a couple of the key points from that journey slide, our pilot was a really great opportunity to get first-hand feedback from real practices in Wales. Each of the practices was asked to try out a minimum of 3 actions from the framework. However, some of them did amazingly well and managed to get up to over 20 actions. So the piloting phase really helped us tease out any sort of niggles in the IT and any other issues that we're now looking to resolve with SOS UK prior to our launch. Okay, so following on from the pilot then, we're now planning for our soft launch on May the 10th. And this is an invite-only webinar for those practices that submitted an expression of interest to join the pilot, but unfortunately didn't make the kind of final 12. Those who join the webinar will receive a live demonstration of the framework. They'll have an opportunity to hear from pilot sites and to ask us and them questions, and they'll get early bird access to the framework 1 month ahead of the national launch. Next slide, please. Okay, so following the soft launch in May, we're planning to officially launch the framework on a national basis during the week commencing the 6th of June, and this is to coincide with World Environment Day on the 5th of June. We've teamed up with Public Health Network Cymru to deliver a free webinar on June the 8th to anyone with an interest in this agenda. We've also secured support from the Minister for Health and Social Services and the Minister for Climate Change, and they'll both be doing pre-recorded pieces to camera for us to raise awareness of our launch. So we're really pleased to have support at such a high level for this, and we've certainly got a lot of exciting things ahead of us. So that's it for me. I'm going to hand back over to Sian now to finish off our presentation.
So just a few more slides, but before I do, I'm just very conscious we've got Dr. Terry Kemp on the call, and we have made reference quite a few times to your RCGP toolkit, and you're probably sitting there thinking, why on earth are you doing this when I've already got something that I've been at for years? And I have met you once many moons ago before COVID, and we did have a conversation around the whole Welsh agenda. And I think since then, it's become more apparent the need for us to do something slightly different in Wales because of some of the direction of travel of our decarbonisation strategy. And for us, it's about working across all primary care contractors. So you will recognise a lot of this. Some of it is very, very similar to the toolkit that RCGP do for UK, and we wouldn't be discouraging practices to do that, but there will be actions in ours that wouldn't be in yours that are very relevant to Wales, and all the information in ours is very bespoke and tailored, signposted to what's going on in Wales. I'm picking up nearly everything that's been discussed today, so a lot of the work that Simon's discussed, a lot of the resources will all be available through that framework. So what we've tried to do is have a very coordinated approach in Wales to bring together all of these bits of the jigsaw that's happening. So that's why we're sort of going off piece and doing something different. And I suppose my last comment is our aspiration on this is very much for this to be done at a cluster level across multiple settings, and that's what we'll be working on over the next 12 months. We're starting with individual practices, but really we'd like people to come together and think about what they can do for their cluster populations. So that's where we want this to go eventually. So finally, in summary, for the people on the call today, as Angharad has said, we are going to go for a launch in June. So if anybody's particularly interested and wants to make sure that they don't miss out, please email us and we'll keep you on a list and we'll make sure you get all the information that's coming out to that launch so you don't miss it. Once it's launched, you can register. There's information on our Primary Care One website. We've made reference here to I'll call you Dr. Sarah's group, the Greener Practice Wales group, but also tell your colleagues to get involved with this or anything else. Next slide, please. And I suppose where we've been coming from, I work for Public Health Wales, so we have a lot of pushback around, is this really going to make much difference? So we're just scratching the surface with this, but it's about making those small steps. And what we want is lots of people doing small actions, not a few people doing really big actions and doing them really, really well. What we've discussed with our pilot sites is that we've had feedback from them that this has been quite a good nudge for them to start somewhere. and hopefully the framework will just give them some ideas of some of the things that they can do. So this is very much around starting the journey for some of those practices. Our ethos is very much around doing it as a practice team, not as a clinician necessarily on your own. Not just one clinician in a practice is taking on board the whole team, and actually some of the non-clinical members of staff are the real advocates for this work. We're working with the practice managers, and they're doing a great job in trying to sort of embed this in their practice. As I say, the uniqueness of us is that we're trying to take forward all 4 contracted professions at the same time for those generic actions. That's giving us some leverage in-house with Welsh Government and things like that, where we're trying to influence the agenda for primary care and make sure that at some point in the future, any funding comes down to primary care as a whole to support this agenda. And again, we've talked about professional organisational responsibilities. We'd like to see this in health board IMTP plans and cluster plans next year. So we're working with health boards and clusters to try and make that happen. And as I said before, it's around sort of scaling this up beyond individual practice. That's it from me. Next slide, please. I think that's the end. Yeah, fine. I'll be here till 9 o'clock, so we're happy to take questions at the end. Thank you.
So I'm Matt, I'm a GP. I work in Yorkshire, and I do part-time GP work, but the rest of my time I think about carbon calculation, carbon literacy, decarbonisation plans, carbon calculators. Basically, I can't say a sentence without the word carbon in it, and if I do, you'll know that I'm unwell. So I'm going to do a quicker presentation than previously planned, but I'll put links in to the chat afterwards. Carbon. So first of all, carbon literacy. What is it? It's an awareness of the carbon cost, the greenhouse gas emissions, but also the motivation and the ability to reduce these. Carbon literacy is really important because we keep hearing this word carbon footprints, but actually, do we really understand it? And this carbon literacy helps everybody start from the basics and work up from there. So I'm not going to go into a whole course on carbon literacy, but it's just to say that for me, this is the absolute bedrock of understanding. If we want to reduce our greenhouse gas emissions, we need to understand some of the language, some of the terminology behind it. A carbon footprint is all of the greenhouse gases that are emitted by a person or a service or a practice or a health sector, and is converted into a single currency, a single unit that we can use to express all of the different gases that are involved. And this is a carbon dioxide equivalent. So when I say carbon, what I really mean is carbon dioxide equivalent. When I say carbon dioxide equivalent, what I really mean is the relative harm that is caused by all of the different greenhouse gases that cause global warming and climate change. Just in terms of some numbers, we've heard that in Wales we've heard 1 million tonnes. The NHS collectively is 25 million tonnes, but actually, what does that really mean? What does that mean for you and I? Well, on an average year, an average person in the UK emits about 13 tonnes of greenhouse gases or carbon dioxide equivalent, about 35 kilos a day. Over our lifetime, that's about 1,000 tonnes. It's just worth having those sorts of ballpark figures in our minds. It's a bit like if I said to somebody that their cholesterol was 5 or 10, actually you've got a reference because you start to recognise what a big number is or a small number. If we want to prevent the worst impacts on our health, as we've heard in particularly in the first talk, actually we need to be reducing those gas emissions, and we need to be getting down to much closer to under 10 kilos of carbon dioxide a day rather than the 35 that we're at the moment. But for me, I'm positive about these things. I honestly think that we know what we need to do and we know how to do it. So for me, this is about taking action. The bedrock is becoming aware, is understanding what carbon is, and this is, or what greenhouse gases are, and that's carbon literacy training. The second is about knowing our number. How can we reduce something if we don't know what it is, if we can't measure it? And I'll talk a little bit about carbon footprinting of practice and how everybody on the call today who's part of a practice can do it for your practice tonight. The next is, well, if we've got a number, what are we going to do about it? Well, we need to have a plan. And we need to turn that intention into action. We need to do something. And then finally, we need to tell other people. We need to use our trusted status, our trusted messenger status, and declare a climate emergency as individuals, as practices, as a sector. So just going back one step, we had a carbon footprint of a person that was about 35 kilos a day, but actually for healthcare, we need to understand what that looks like for the things that we use on a daily basis. So, for example, we've heard a fantastic talk about carbon emissions or greenhouse gas emissions from Ventolin inhalers, for example. So one Ventolin inhaler is around 25-30 kilos a day. So one Ventolin inhaler is about a day's worth of emissions for each and every one of us. GP appointment, this was pre-COVID, about 66 kilos. 1 month of omeprazole, about half a kilo. But it's not just the individual amounts, it's actually how many of these things do we do. So you can tell that this is pre-COVID because the NHS was, or primary care was only doing 300 million patient consultations a year. I think we're up to about 350 million each on a daily basis, or so it feels at the moment. So we saw at the beginning, in the beginning talk, what the footprint of the whole of the NHS looked like. But actually, for me, I want to know what it looks like in an individual practice. What's the breakdown, and what does the practice look like? What does my practice look like? Well, actually, there's about a 60-40 split in carbon emissions or greenhouse gas emissions between the clinical and the non-clinical. The clinical is the inhalers, is the medication, and I'm not going to touch on that. We've had some information about that so far. And the other bit is about the running of the practice, the energy, the travel, the services, the supplies, the goods that we have. And actually, we can break that 40% of our practice emissions down a bit further. This is some work that I've done in urban practices in Salford. So we've got energy, 35-40% for these practices on average. Staff and patient travel, another third. Business services, so finance and payroll and IT and broadband and all the rest of it. Business services about a quarter, and then procurement about 10%. So this is the office and medical goods and consumables that we have. And absolutely, the waste is tiny. So thinking that we can recycle our way out of the climate crisis is an absolute non-starter. So for me, we need to know our number. If we can't measure it, we can't improve it. We do it with blood pressure, we do it with blood sugars, and actually there is a free online carbon calculator for non-clinical carbon for our practices that we can use today, and I will put this link in the chat afterwards. But you basically put in your numbers from your practice. It's anonymous. It's a locally saved data, which means that you whichever computer you enter the data on, that's the only computer that knows the information. Nobody else does. It's not shared with anybody. It's personal to you and to your practice. But what it means is that you will get a pie chart with where your hotspots are. So you actually know for you, this is not some national average divided by the number of practices, but this is you in your place of work. And actually, then what we need is a plan. We need something with a trajectory. We need something with milestones, with 3, 6, 9 year or 2, 5, 7, whatever number of years we put in. So actually, we can put in place actions to reduce the carbon, high quality patient care, better patient and population health, and less environmental harm en route. And so one of the things that practices can do with the help of the toolkit is identify those actions, start to measure the changes that they would expect to see in environmental harm that's otherwise caused, and we start to see a trajectory. We start to see how we can get that reduction by the end of this decade. By 2030, we've got this. We know what we need to do. We know how to do it. It's just a matter of doing it. So take home message from me is carbon literacy, very, very important. We need to have that baseline of knowledge. We need to know what our numbers are in individual workplaces and individual practices. We need to have that plan at personal and practice level, and then we need to tell everybody else about it.
I'm Jackie Reynolds. I'm a prescribing pharmacist and I work in a GP surgery in near Caerphilly in Oakfield Street. And I also work as a prescribing advisor and a respiratory lead pharmacist for primary care in an Iron Bevan Health Board. And I'm going to talk to you today about some of the things that we've been doing in an Iron Bevan to try and address the green inhaler agenda. And we've heard a lot about the problems with MDI inhalers. But I'm going to talk about some other problems with inhalers, which if we can focus on these areas, will not only improve outcomes for our patients, but it'll also be better for the planet. So I know Simon mentioned about that this is not about inhaler technique, and it's about changing culture and prescribing culture. And I'd agree with that, but we do need to think about inhaler technique, because there's a big problem with patients not being able to use their inhalers correctly. And this paper from 2016 by Sanchez looked at data spanning the last 40 years. And despite all the technologies that we've had with different devices, different medications, only about a third of patients, or just under a third of patients, whether that was asthma or COPD, can actually use their inhalers correctly. And another paper then, the critical study by David Price, this was in 2017. He, in his paper, he demonstrated that 70% of patients make one or more critical errors with using inhalers, and that was with MDIs and DPIs. But I will sort of qualify that by saying that MDIs are the biggest, really, the device that we get wrong. So there is genuinely an opportunity to get better inhaler technique and get better outcomes by focusing on correct inhaler technique and moving away from MDIs that people can't necessarily use. And the lowest error rates were with MDIs and spacers, but we all know the problem with spacers is that patients don't use them. So they're not a panacea for a poor technique with an MDI. Maybe the reason why patients are not very good at using their inhalers is that as healthcare professionals, maybe we don't understand how the inhalers should be used correctly either. And this study, it's done in 2010, so quite an old study, but it demonstrates it nicely, because this study, they asked 150 healthcare professionals, and these were doctors, nurses and pharmacists from primary and secondary care, and asked them to demonstrate how to use an MDI device. And only 7% could correctly identify all the steps that are needed to use that device correctly and have the correct inspiration for that device. And probably more alarmingly with this was that 111 of those 150 healthcare professionals were regularly involved with teaching patients inhaler technique. So I would argue if we can't get it right, then there's probably no chance for our patients. So it is important to educate ourselves on the devices that we prescribe. And for the drug to be clinically effective, really we need to be making sure that that device is correct for that patient, because it's the device is probably more important than the drug, because if they can't use the device, then the drug is not going to be effective. And probably the biggest problem that we've got with inhalers, and the biggest contributor to the greenhouse gas emissions, is the overuse of salbutamol or reliever inhalers. And in asthma, this is defined in the Sabina study, which is quite a recent sort of global study, with patients using 3 or more canisters of Saber MDI in 12 months. And they mapped this out, and they've shown that it's associated with poor asthma control, twice as many asthma exacerbations, and increased healthcare utilisation. So a really good, and again, NRAD I've not sort of talked about this here, but if we think about the National Review of Asthma Deaths, one of the recommendations for that was to focus on patients who were overusing their SABA inhaler. And then when we look at this SABA overuse, it's estimated that in the UK, 83% of the SABA we prescribe is to patients who are having 3 or more inhalers a year. And this is responsible for 67% of the greenhouse gas emissions from all inhalers. So if there's an area that we need to focus on, it has surely got to be cutting out and reducing SABA overuse. Next slide, please. So this was just a more recent study which gives the same sort of information, and you can see where the UK sits in Europe and Canada. So in the bar chart on A, you can see that the dark thick line, this is SABA inhaler versus total inhaler use. So that's about 60%. So 60% of the inhalers we prescribe are SABAs. And Simon's already told us that they're probably the least effective in terms of managing our patients with asthma and COPD. So we need to address that. And then they account for, in this study, 68% of all the greenhouse gas emissions. So again, if we tackle this overuse, and if you look at then at B, the graph there, you can see that out of the Sabina studies, out of the Sabina countries rather, the UK has the highest SABA overuse in Europe. And then no surprises if you look at C, that then that equates to the highest greenhouse gas emissions associated to that in Europe as well. Next slide, please. And I really like this study. So the Sabina program, which was looking at SABA use in asthma, they then looked at how does that match to carbon. So there's now a Sabina carbon study. And this really nicely shows that if you look at just the donut at the bottom, that uncontrolled asthmatics contribute over 3/4 of the greenhouse gas emissions compared to patients that are controlled. And you can see then from the bar chart that you've got overall admissions associated with controlled asthmatics, non-controlled asthmatics, and you can see that the non-controlled asthmatics, and so they're defined as using 3 or more SABA inhalers a year or having 1 or more exacerbations a year. Those emissions are greater. And the blue bar charts is the emissions that are related to SABA. So you can see that most of those emissions are related to the use of SABA. So that's something that we need to address. Next slide, please. So in Aneurin-Bevan, we wanted to take a holistic approach. So I'm hoping you can see that trying to be greener in our inhaler prescribing is not just about switching MDIs to dry powders. We do need to do that because the majority of patients that we have on MDIs probably are not using them correctly. And if you were to think about most patients' default breath in is a forceful breath in, which is the breath that matches a dry powder device. And really our MDIs, we're still going to need them because our sort of younger patients, our very sick patients, and maybe our elderly patients who are unable to use a dry powder, they would still be reserved for them. But the majority of our patients should be able to use dry powders correctly. So within Aneurin-Bevan, we produced this document which tried to just put all of the resources that we've heard about tonight into one place. They're easily accessible for our prescribers, and then it aligns to the inhaler initiatives in the decarbonisation strategy. So just to recap on what they are, is that it's taken a patient-centric approach to optimising inhaler use and focusing on this reduction of the over-reliance or blue inhalers, where suitable transition, and we've heard about this sort of from existing high carbon inhalers, so there are MDIs, to lower carbon alternatives, so our dry powders and our soft mist inhalers, and then to encourage responsible disposal of inhalers. So going round this document, the buttons, the blue buttons, are sort of interactive, and if you click on those you will get more information. So it's looking at things like choosing the right device in the first place, then choosing the right medication, so we can use our All Wales COPD and asthma guidelines to help us there. Not mixing devices. So if we've got, how many sort of patients do we have on a dry powder preventer and then a MDI reliever? So it's about not mixing devices where possible. There are caveats to that. Optimizing their inhaler use, so making sure that if they are on an MDI, that, you know, encouraging them to use that spacer. Using the apps for self-management, making sure that we're focusing on this SABA overuse, minimizing the propellants that we use in the MDI, and that's one of the sort of switches that we've done with Ventolin to Salamol. But you may have also noticed, if you've looked at the guidelines in any detail, that on that first step for asthma patients, where we might have given, for instance, if we are prescribing an MDI, we may have given a Clenil 100 device. Then now the guideline is saying give a Clenil 200, because we will, it has a lower carbon footprint if we give a higher dose but fewer puffs, if that makes sense. Then it's about reducing waste, so just encouraging patients to really only order what they need. I mean, how many patients have their blue inhalers just literally everywhere, and they're very fixated on them, and we need to really try and change that, and that's really only going to be through education. And then encourage responsible disposal. Next slide, please. So you may or may not be aware that to help us with the decarbonisation of inhalers, there is a new Wales National Priority Indicator for the decarbonisation of inhalers this year. So this will be in prescribing sort of incentive schemes. And this is to encourage an increase in the use of low global warming potential inhalers. So that's your dry powders and your soft mists, to reduce the carbon footprint of inhaler prescribing in Wales. So the unit of measure is the number of dry powders and soft mists as a percentage of all the inhalers prescribed. And it's about maintaining our performance within the upper quartile or showing increases towards that, the quartile above. Next slide, please. So one of the ways that we can achieve this indicator is the obvious. If we focus on the numerator, we need to increase the number of inhalers that we prescribe as dry powders or soft mist devices. So when we start inhalers, we really need to be thinking about assessing inhaler technique and preferentially choosing a dry powder and a soft mist device if appropriate. And we've got some guidelines to help us with that. So there is the NICE asthma decision aid, which can help us, or there's another guideline that there's a link there too, and I think these slides are being shared, so you will have these links. The other area then we can think about is switching our patients who are currently prescribed an MDI to a dry powder or a soft mist inhaler as an alternative. Now, currently the soft mist inhalers are very limited, so really they're sort of more of a range for COPD patients, but we're probably talking more about changing to a DPI here. So the patients to target would be those on mixed devices. So if they're already on mixed devices, can we change that? And maybe they're the ones that could be changed more easily if they're already used to using a dry powder for their maintenance therapy. Targeting those patients who are uncontrolled on their current MDI. So the ones that are coming back having exacerbations, using lots of SABA, they would be the focus of, well, maybe then you know, they can't use their MDI, should we be changing them and thinking about a different device? So this is really going to involve face-to-face reviews. I've tried doing inhaler technique consultations over the phone. You can do it to a certain extent, but it's better if you can do it face-to-face, so via a video or obviously in person. We can use the COPD and asthma guidelines to support appropriate alternatives, because they can guide us with appropriate choices. And we're very lucky in in an Iron Bevan, because I have a very clever colleague who is developing a decision support app, which will sort of sit on practice desktops, which will help to if you are thinking about changing or switching inhalers, to sort of make sure that we're switching patients to an equivalent drug. Next slide, please. So the other area to achieve this indicator, we can focus on the denominator. So that's about decreasing the number of inhalers prescribed. And the biggest area that we're going to make an impact here is by reducing reliever over-reliance. So looking at things like MART therapies with asthma, so not prescribing a SABA at all, but using a maintenance and reliever therapy. And that can be quite an effective strategy for patients who are quite sort of fixated on their blue inhaler and then don't take their ICS. If they only have one inhaler with an ICS LABA, then that's the one they're going to be taking. And it's interesting that in the global asthma guidelines, a ICS formoterol inhaler is their preferred reliever now. So they're getting rid of SABA, basically. We can reduce the quantities on repeat to prompt a review or to issue as an acute, and that would be up to sort of individual practices. And then ensure asthma and COPD patients are optimally managed. So not keeping patients on suboptimal therapy needing lots of SABA. We need to be thinking about stepping them up if they have the correct technique and they are adherent to their therapy, obviously addressing those issues first. And then encouraging patients to only order what they need to avoid stockpiling. I think I'd be quite rich if I had, a pound for every time I've phoned a patient to say, do you really need this? You've ordered this blue inhaler again. Do you really need it? And they tell me, no, I've actually got loads at home. I've just ticked it by mistake. The pharmacy have given it to me, or, my husband, mother, daughter went to the pharmacy on my behalf and ticked everything. So I think this thing about maybe not having them routinely on repeat is a good idea. And then looking at, and also they sort of obviously avoid stockpiling and collaborating with your local pharmacies to do that and working together. And then decreasing the number of inhalers prescribed by switching to multiple inhaler therapies. So rather than having somebody on a LABA and a separate LAMA, can we put them on dual LABA-LAMA? The same with triple therapy, obviously if that's appropriate and the drugs in those devices match what that patient needs. But that's a quick area of using those single inhalers. And even if they're dry powders, that's still better to have. It's less plastic to have, one inhaler that does the job of two. Next slide, please. So breaking the cycle of SABA over-reliance, there's a few things that we can do here, and I've touched on some of them. So in the interest of time, I'm not going to go through this. But the biggest thing is education before medication. And it's really making patients understand that that SABA inhaler is really for their rescue treatment. And really, what does it do? It's, compared to with asthma, compared to their ICS, if they're only going to rely on their SABA, they're not managing their asthma. And then this sort of card that keeps sort of moving back and forth on your screen there, that's the asthma right care slide rule, which can be quite interesting to use with patients and other colleagues who think it's okay for a patient to have a salbutamol inhaler every month. Because if you have a 200 dose salbutamol inhaler every month, then that means, and you're using it, that is 7 puffs per day. And would we be happy with somebody that's having to use their inhaler 7 times a day? Or are they just stockpiling or over ordering? Next slide, please. So in my practice, we've been looking at this. We've been focusing on patients ordering 3 or more SABAs per year, and then they've been flagged for me to review, and not just me. This is the practice nurses as well, and we've had some success. So this is the dashboard, and you're going to get a more of an in-depth talk on that in the next presentation. But you can see on the left-hand side that since we've been looking at this, that we have reduced our carbon footprint. So this is all of our inhalers. This is not just SABA. And although we're still not particularly good at the percentage of dry powder and soft mist inhalers, we've got lots of work to do there. And I think we've shown an increase. And this isn't something that's going to happen overnight. This is about, as Simon said, it's about changing culture. It's about embedding these things into our routine practice, and also sort of educating patients for, what's the right treatment for their condition. And I think when we last looked, I think in the last year, we've had a 20% reduction in our salbutamol prescribing. So we're pretty pleased with that, but we're only just scratching the surface. So next slide, please. These are just some resources that we've used. Most of these have already been discussed, so I won't dwell on any of those. And I think that's me.
So I'm Kath Haynes, head of the Welsh Analytical Prescribing Support Unit, WAPSU, which is part of the All Wales Therapeutics and Toxicology Centre. And we have developed a dashboard to report on progress in reducing the carbon footprint of inhalers used within primary care in Wales. The data within comes from the shared services dispense prescriptions in primary care information and is therefore 6 to 8 weeks behind, as you know. So Stephen Griffiths, you can see there, a senior data analyst with us, is the brains behind this dashboard. And the dashboard works on reports on several key metrics at a health boards, cluster and GP practice level to support all practitioners in reducing the carbon footprint from inhaler use. It's officially launched now and is available to all NHS staff on our Spira tool, which is available on via the AWTGC website. It's available via the NHS network only, but I can add the link in the chat for anyone who would like to have a play around with it. So we're hoping that this will be another helping tool to aid in our All Wales progress towards inhaler decarbonisation. Thank you, Jenny. I'll hand over to you for playing the video, if that's all right now.
That's great, Kath. If you want to send me the links, I'll make sure that they're circulated to everybody that's joined the call today as well.
Welcome to the presentation of the decarbonisation dashboard we have developed. Today, we will give you a brief summary of the dashboard. It is a web-based dashboard and is fully interactive for the users. This presentation highlights the main parts of the dashboard. When we demonstrate the dashboard to users, we have carried out interactive sessions via Microsoft Teams. The aim of the dashboard is to help support health boards in decreasing the carbon footprint of inhalers. The dashboard is structured to start at a high level and then move to more detailed breakdown of the information. There are a number of different pages to suit different users. The first page is very high level and is intended to be the least technical. It summarises the progress for each health board and for Wales, using public-friendly terminology, with the use of pictures helping to draw people's attention. The idea of this page is that it can be shared with the general public, maybe via the health board's own website. Sharing this page will help inform the public and enable them to connect to why this is important and the progress the health board is making. This page is set to A4 and therefore can be printed or downloaded into a PDF for ease of sharing. The next page is a key questions page. This is designed for key stakeholders with high-level questions, therefore very visual, so the answers can be viewed quickly and easily. These key questions might change over time or to highlight different areas of focus that might change with changes in policy. The first question is based around the progress of health boards and clusters. Which health boards are showing an increase in their carbon footprint and which health boards are showing a decrease over the past 3 months? Likewise, the top 5 clusters where the carbon footprint has increased and the top 5 clusters where the carbon footprint has decreased. The charts in the next section show the information from an inhaler's point of view. On the left-hand side, you can see which inhalers have the greatest carbon footprint, represented by the size of the bubble, and the percentage change over a 3-month period represented by the colour of the bubble. Users can hover over the bubble for further information. The chart on the right-hand side shows all MDI inhalers that have a carbon footprint greater than 20,000 CO2 kilograms per month. The size of the carbon footprint is represented by the colour of the bar and the percentage change represented by the height of the bar. Here, we would want to see large, dark, blue negative bars to show inhalers that are contributing the most to the carbon footprint are reducing. Bottom chart will help inform which inhaler is being switched to. The colour of the bar represents the total carbon footprint for the latest month, and the height of the bar represents the change of the past 3 months. This could be used to track policy or advice given on switching. Throughout the dashboard, the user can hover over the charts to gain further information. The next page looks at the data from a health board's point of view. On this page, a user can select a number of different measures using the drop-down box. These measures are carbon footprint per 1,000 patients, spend, number of items, and the DPI and missed inhaler usage as a percentage of total usage. The user can see the change for each of these measures over a short term, 1 month, a medium term, 3 months, and a longer term, 1 year. The chart below enables the user to visually see the percentage change quickly and make it easier to compare the data. The bottom 2 charts plot the selected measure over time. One plotting the measure versus the actual date, and the other plotting the measure versus a 3-month rolling average to smooth out the peaks and the troughs. The next tab enables the user to drill down deeper into the health board structure and to analyse the data at cluster level and at a practice level. Again, there's a drop-down filter where the user can select which measure they want to look at, plus they can filter on the date and the health board. Users can filter on the health board to only show cluster and practice related to that health board. All the information related to the other health boards will disappear. Or users can highlight the health board to only highlight the cluster and practices of that health board amongst all the other results. There are a number of different charts, for example, box whisker charts, bar charts, and scatter charts to help compare practice level information. Again, users can hover over the charts to show the tooltip for more detailed information. The previous few pages looked at the data from a health board, cluster, and practice point of view. This page aims to look at the data from an inhaler's point of view. Again, we can select different measures and filter the data at a health board level or at a cluster level. The first table shows a change in the top 10 MDI inhalers for a short, medium, and long-term time frame. These are the inhalers we want to be switching from. The next 2 tables look at the change based on the inhaler type and the percentage usage. Over time, one would hope to see a reduction in the MDI usage compared to the DPI and missed inhalers. The third table shows all non-MDI inhalers. The aim is to see which inhaler is being switched to. The last table enables you to explore any inhaler. For example, all patients might not be able to switch to a DPI inhaler. Therefore, users may want to explore which MDIs are increasing and hopefully they have a lower carbon footprint. This data could be used for other examples and can be exported to Excel for further analysis. The next page aims to help users make an informed decision of which inhalers to switch from and which inhaler to switch to. Users can view data at health board, cluster, or practice level, which will update the results in the tables. Users will be able to see a list of the top 5 inhalers based on carbon footprint. These would be the inhalers you would want to concentrate on switching from. Below, users can select the inhaler they want to switch from and either select the inhaler you would like to switch to or bring back a list of inhalers using the filters. This will update the tables to show the reduction in the carbon footprint and the cost of switching between the different inhalers. There may be a trade-off between cost and reduction in carbon footprint. For example, I could switch at no cost to an MDI inhaler and get a reduction of 2.3 million reduction in carbon footprint, or to an DPI inhaler at a cost of 180,000, but you get a larger reduction of 3.3 million in the carbon footprint. The graphs help visualize the results in the table. Again, hovering over the points showed further information. The next page will help the user put into context what switching from one inhaler to another has on the practice and cluster. Once the user knows what inhaler they would want to switch from and the inhaler they want to switch to, they can use the following dashboard to estimate the reduction in the carbon footprint and the change in the spend. It might not be feasible to switch 100% of the patients, therefore you can estimate how many you would like to switch. Then the statement below will state the potential outcome, change in cost and carbon footprint at an overall practice and cluster level. The practice summary dashboard concentrates on the individual practices. It shows a number of measures for the current month and the top 5 inhalers by carbon footprint, plus short, medium and long-term changes and a trend line for the different measures. Also, the performance of the practice versus all other practices. Practices can use this page to help inform and monitor progress. The next page enables a user to filter the information they require and export into Excel to carry out their own analysis. The views in the dashboard contain a certain number of measures and compares certain timeframes. This page enables a user to do their own analysis. The next page allows a user to filter on a single inhaler. This would be useful if you wanted to see the effects of any particular inhaler with a range of different measures. These different measures can be used depending on who the user is talking to. It might be better to use car miles and CO2 kilograms if you are talking to a member of the public. The last page includes a summary of the main information we are using in the calculations within the dashboard. It also helps provide some level of transparency. Also included on this page is whether the carbon footprint value is a manufacturer estimate or research-based figure. That's all on the decarbonisation dashboard. If you have any questions, feel free to ask now or send me an email. Thank you for your time.
I am now going to pass over to the wonderful Dr. Richard Thomas, who will give an update on the Swansea area and take any discussion topics that we would like to take offline. We've got 11 minutes, Richard, until the official end. So over to you. I'll share your slides now.
I was a teenager in the 80s, which meant that Madonna was singing. She was a material girl living in a material world, and I think that what's changed when we hit the COVID pandemic was that suddenly we moved very much into the virtual spaces. I'm not going to talk about what's been going on very much in Swansea because time is short, and I do want you to have some opportunity to ask questions. But I do want to think about what's changed in terms of us moving into a virtual world, because actually it's one of the things that makes a difference to our carbon footprint. And it's something that you will notice that the rhetoric in Wales has been very, very different from the government about using telephone consultations and compared to face-to-face. And I think that's probably a good thing. So I want to think about how we're using these tools and whether they are as effective as we would like, and actually, what the benefits are of them. Can I have our next slide, please, Jenny? So when the COVID pandemic hit, I'm a college examiner. The exit exam changed from CSA because you couldn't take people to London to the recorded consultations assessment, and after the first sitting it was obvious that actually people were struggling to find appropriate cases, so we had a virtual exam course that ran between the July and August sittings of the exam, that was all delivered online. We've all to an extent got used to this online delivery of training now, that it's much more it's much more widespread. It's certainly got some downsides. I think it's very much one way. It's difficult to interact with your audience as a presenter. It's difficult to run breakout rooms. They don't feel very effective. You can't just break off into small groups and get people to talk about things and come back. And the questions that come through chat are not the same sort of thing that you get when you're presenting in the real world, and you can see that people don't understand things. So this loss of the visual feedback is an issue for us. And there is always the risk that people are being distracted by what's going on elsewhere. You've got to balance this against the fact that actually what we're delivering is now much more accessible to people. As Jenny said, this is recorded in our RCA courses recently. I think we have had something like 90% of the applicants, not just from the M4 corridor, which is what used to happen in our CSA courses, but actually 90% of the applicants, the people coming to the conference, the delegates rather, they're from outside Wales. So not just North Wales, but people from Northern England, people from Scotland. So actually, we've got a much more geographically equal delivery of training. Much wider geographical spread. It's cheaper, it's easier to get access to, and it's egalitarian. So that means that accessibility is likely to be a good thing. I'm not certain that we've got the balance right. It's still very difficult, and I think that the tools do need refining. There are issues around how quickly you can get responses. If you've got several people in a meeting, people talk over each other, and it's very difficult to identify how we work around that. But it's going to be an important part of how we deal with delivering training for general practice in the future. Is this mix of face-to-face meetings and virtual meetings, because you do lose something by not actually seeing people face to face, by not having the opportunity to have a discussion over coffee in between presentations or so on, and those informal networks that we build up and that are very important. So some questions there for us, but this is something that I've been trying to deliver on, and which is where this is as well this evening. Can I have the next slide, please? The other thing that, as I mentioned earlier, in Wales, we have not had the great push to go back to face-to-face as the default mechanism of consulting, and that's partly because Welsh Government believe that they want to reduce travel, and also because Welsh LMC Conference adopted telephone consultation last year during their conference as something that we should be aiming for. So we're going to have this continuation of trying to keep consulting remotely. I know when pandemic hit, our consultations dropped, face-to-face consultations dropped to about a quarter of what they had been previously. And when we looked at the postcodes of the patients who would have been coming in to us previously compared to those that we were dealing with on the phone, actually that meant that we were potentially reducing travel by about 360 miles a day across the surgery from patients. The absence of electronic prescribing meant that actually only about 1/3 of that was realised, because people were having to come to the surgeries to to collect their prescriptions, to go and get them cashed, which is why that's something that LMC Wales, or Welsh LMC Conference, and GPC Wales and various other people are pushing for e-prescribing. But this move to telephone consulting is something that is it's not going away. And I thought it was going to be a great solution to some of the travel issues. As time's gone on, I'm sure that you've all had the same sort of problems that I have. Consulting on by phone it's more demanding, it's more wearing, it's more tiring, it's not as rewarding. I don't laugh in my consultations anywhere near as much as I used to when I was seeing people face to face. So it feels slower. And the trainees who are coming through at the moment, for whom this has become largely the default, I think what's happening with the college exam is actually making things worse, because it's very frequent now for people to be taking one consultation to take a history, that's 12 minutes, and then another consultation to see the patient. So they're taking 24 minutes to deal with problems that we would have been dealing with previously in about 10. Telephone consulting, it's become embedded. I mean, we were doing probably about a third of our consultations by phone pre-pandemic. No, a third of our acute contacts, not the planned stuff. And we are still doing the vast majority of it by phone. It's weird, I think, that we haven't adopted video consulting. I haven't adopted video consulting to anywhere near the same extent. I've pretty much given up on it. I think that's because it's a cumbersome tool, and again, there are issues around latency with the interactions with people. And that's bizarre, because I'd much rather FaceTime my sister who lives in Australia than I would ring her. But the platforms that we have, I don't think are necessarily adequate at the moment. So that's something that, as a group, if we want to have video consulting, we are going to have to address that, because it feels to me like it's a more difficult way of consulting than telephone consulting is. And that's primary care. It's not clear to me how effective telephone consulting is for secondary care. You know, that reducing that patient travel is going to be something that's very, very important. But I just don't know. I'm not entirely sure how effective it is in primary care. You know, there is still multiple issues with it. Patients often don't want to reveal things unless they're face to face, and that's an increasing issue for my practice. Could we have the next slide, please? So I think there are questions around how we develop consulting skills for people, including how we make effective use of electronic triage, so that we are bringing that when we've decided that patients need to be seen, we're making that decision at the triage platform stage, and bringing them in to be seen, rather than them having a whole consultation and then being brought in subsequently with all the issues around how do I get to see the same doctor, how do I deal with it, and this is all part of some of the skills that we're going to have to think about how we develop for ourselves and for our trainees. How do we deal with email consultations? You know, it's a one-way answer. So there are some challenges that have become apparent to me from things that have stemmed from COVID and how we've responded to it, and that look like they should be solutions to some of the carbon footprint of travel, but I don't think we've got there yet. So that was very much a shortened presentation from me. The floor is open for questions from anybody, really. So thank you.
But I'd like to thank all of our experts who presented this evening, and I hope you've agreed that this was an extremely informative and inspiring webinar. And it's wonderful to see so many primary care organisations working together to look towards a sustainable landscape in primary care.
while you're thinking about it, please can I ask Claire Willis a question then, because she's put in the chat, please embrace RD/RA in the meantime to reduce the need to get script to pharmacy, but at least 6 times. I don't know what RD/RA means, so perhaps somebody would educate me. Thank you.
Thank you, Richard. And take the dog. Did anyone answer Richard's question?
I think RD means repeat dispensing.
Yeah, I was going to say I can pick it up if Claire. I wanted to see if Claire herself wanted to mention it. Yeah, it's repeat dispensing. I don't know what RA means. So it's where you're issuing 6 scripts in one go rather than repeated scripts. And there is a facility in Wales for that to happen. We don't use it that often, but we probably need to promote it more, particularly for this agenda. So it means you would be given a patient 6 scripts in one go, and then they would cash it with the pharmacy, and then they'd go back and repeat rather than having to come back and forth, back and forth, back and forth.
I can see some more chats. So Claire said that batch describing is possibly better description and reduces patient and pharmacy travel and time, but why include 2 puffs 4 times a day when needed as a dose? But yeah, patients.
Can I go back and raise another question that Claire put in the chat earlier on? Do patients really understand what's meant by poor control? Do they understand the consequences of poor control? And I think the answer to those is no, but I think the more interesting bit of the question is what phrases can we, she's written as pharmacist, but it's for all of us, used to reinforce the message. After all, it's usually, she said, to the community pharmacist, it's them who are being asked to request a prescription, and that's not something that we do in our practice. But there are still those questions around how do we frame these discussions about what is adequate control, what is poor control, and I'm wondering whether anyone on the panel has got a suggestion on how we do that.
I do. Co-production is crucial here. So this is about patient self-management, and this is about empowering patients to manage their own illness and empowering patients to make the choices which are the right choices. And the patients, when they understand the implications of what they're taking, they will make the right choices, 100%. So, and we focus very strongly on creating some very clever digital solutions for this, and the Asthma Hub and COPD Hub apps are very sophisticated and much better than anything else that exists that you can get, and they're free for patients, and they will help the patients manage their own illness. So I think any intervention that you have with the patient needs to involve getting the patients to be able to manage their own disease. So I strongly advise any healthcare professional who's on this webinar to support getting their patients onto the COPD and asthma apps if that's what the illness they have, and they will be able to drive that agenda and manage their own illness. I think that's fundamental.
Yeah, the other thing I was going to say is that I think having an awareness and using the environmental importance of better control is important, but actually the other aspect is emphasizing that it's about better clinical control, and actually put that push towards a MART regimen where ideally with a dry powder inhaler, it is about you don't need to use the relievers because actually you've got better control, your illness is better controlled, you have fewer symptoms, and these are very, very important aspects of I think what is likely to drive patients to accept the changes. Thank you.
Joe's got a good question here. Joe Sartori. There's a financial incentive for community pharmacies to request repeat medication even when patients have not requested this particular item. So how do we tackle this?
I can understand where that question comes from. I think Claire Willis's answer is right that it's probably not the case. I think a much bigger issue is patients over ordering, ordering tick all boxes, and I think moving things like SABAs to available as acute scripts rather than on repeat prescription, so that they are still available, they're still accessible, but actually it's not something that just comes automatically. I think that's a useful way to deliver it, to reduce the over reliance on it and the over issuing of it. So that's an important thing for us to be thinking about as well.
Can I just come in here as well, Jenny, very quickly? We have a survey that's gone out to all healthcare professionals in Wales about whether we should be not prescribing salbutamol or Ventolin Evohalers. And 76% of respondents, that's more than 300, believe that we should no longer be prescribing those inhalers in Wales. Okay, so the strong consensus of opinion is that we should not be prescribing the biggest components of the carbon footprint in Wales because there are alternatives. That's really worth reflecting on. That's data that's just come out now.
That's huge, actually. Yeah. So thank you for sharing that, Simon. I'm conscious that we are now 11 minutes past 9. I'm really, really grateful to all of the experts today and all of you for joining and remaining on for so long. If anyone's got any more burning questions, please shout now. But otherwise, thank you all so very much. It's been a really important topic, and I think that based on, I'll send a feedback report actually around to all of my lovely attendees. And if there's anything that is particularly of importance to you or you're really interested in, please do let us know, because this has been a highlight of multiple areas today around this topic, and we are in RCGP Wales very keen on making this a priority, so we could do some separate groups, some breakout areas, bigger in-depth looks at any of these areas. So please do work with us, let us know, and yeah, hope to see you all again very soon at another event. And thank you all again for your time.